It's a pleasure to introduce my friend Dr. Kalyan Chakravarthy, who is talking about diabetes, diet, and technology. He has done MBBS, MRCP, UK, CCT, Endocrinology. He has been trained in reputed institutes in the UK for his super specialty qualification and trained extensively in London. His area of interest is endocrinology. Also, he is expert in the diabetes and thyroid. Dr. Kalyan.
Okay. Thank you, everyone. Slideshow is there. Yeah. So I have two talks. I'll promise I'll finish by 20 minutes. So the first talk is about subclinical hypothyroidism. Essentially, we want to see what is the risk of subclinical hypothyroidism in normal individuals and in pregnant individuals. The subclinical hypothyroidism is diagnosed as when the TSH is more than 4.5 with a normal free T4 and free T3. And there should be a persistent elevation. That means 2 consecutive samples should be raised. The consequences of subclinical hypothyroidism, most of them, it's just a little higher risk of cardiac issues in some people, but there is progression to overt hypothyroidism. That is the main risk. The risk is higher in women who have a high TSH level, who have TPO antibodies positive with a normal T4 levels. So the controversies are that subclinical hypothyroidism can lead to cardiovascular events, can lead to mood disturbance and mental health, can lead to goiter and thyroid cancer, and can lead to obesity At present, we treat subclinical hypothyroidism if the TSH is less than 10 only if there is a goiter or there is antibodies or the patient is trying to conceive or there is a progressive TSH increase. Other factors to be taken into consideration are cardiovascular risk factors and dyslipidemia. Almost all the guidelines suggest that you treat only if you have any other factors that are meant to be taken into consideration, which I mentioned on the other slide. So, according to NICE guidelines, they say consider a 6-month trial of levothyroxine for adults under 65 who have a TSH on less than 10 on 2 separate occasions and have symptoms of hypothyroidism. I think this is the take-home slide you can save. If it is less than 4.4, don't treat. If it is 4.4 to 6.9 with multiple symptoms of hypothyroid, positive TPO antibodies, increasing TSH levels, planning for pregnancy or goiter, you treat. Otherwise, you don't have to treat. If it is between 7 to 9.9, again the same risk factors will come into consideration. In adults more than 65 years, treatment is not recommended because the TSH tends to be higher in the elderly population. If it is more than 10, definitely we will treat. Now, in terms of subclinical hypothyroidism guidelines as per the Indian Thyroid Society guidelines, same thing. They say if it is more than 10, treat. If it is less than 10, if symptoms are present or not present and the age is more than 70, don't treat. If the symptoms are present or there are antibodies, treat. So almost all guidelines suggest the same sort of thing. Even this is the European Thyroid Society guidelines. In children, a TSH of less than 10, you don't have to treat. If it is more than 10, then yes, of course, if there are symptoms progressing, you treat. In adults, same guidelines. In pregnancy, because there is increased demand and subclinical hypothyroidism can progress to overt hypothyroidism, there is an increased need to treat this condition in pregnancy. And according to the ITS and FOXY guidelines, the reason to treat is because the adverse events, which is miscarriage, pregnancy-induced hypertension, and preeclampsia, and many other maternal outcomes. In terms of neonatal outcomes, you have preterm birth, low birth weight, and an increased admission to neonatal unit. So these are all the guidelines in pregnancy, but the simple thing is of what is the TSH target. The TSH target is 2.5. There is very low evidence to suggest that the TSH target should be 2.5 instead of 4, but it's a generalized practice now that it is 2.5 that we aim for. In the first trimester, in the second and the third trimester, we aim for a TSH of 3. In TPO positive women who are euthyroid, There is again very less evidence that you can treat. There is only just like some study which says that there is a reduced evidence of preterm birth and neonatal admission in patients who were given thyroxine in TPO antibody positive groups with euthyroid. Then isolated hypothyroxemia, that means patients having low free T4 and low free T3 in pregnancy. The simple thing is that there is no point. You cannot treat it. It's a normal variation. Pregnancy induces a lot of thyroid binding globulin, and therefore your total T4 goes up. The T4 is taken up into the by the protein. The free T4 goes down. It is very normal in pregnancy. So please don't treat free T4 and free T3 lower in pregnancy. The high total T4 and total T3 that occurs in pregnancy is also normal and does not need to be treated. It is only the TSH that needs to be at 2.5. So in pregnancy, if the anti-TPO antibodies are positive and the TSH is more than the pregnancy specific range, yes, you treat. If the antibodies are negative but the TSH is more than 10, again, yes, you treat. If the antibodies are positive and the TSH is more than 2.5, but less than the upper limit of normal, you consider treatment, but there is little evidence to suggest that this is going to make any real benefit. If the antibodies are negative and the TSH is more than upper limit, again, you consider treatment. So this is the dose. This is more than 2.5 we should treat, and we should monitor the TSH every 4 to 6 weeks. I would ideally suggest monitoring only in the first trimester. In the second and the third trimester, once every 2 weeks is fine. So with that, I finish my first talk. Now, this is my actual talk that I was supposed to talk. So I'm going to be talking about diet and technology. I am very interested in insulin pumps and technology. So I would be more than happy to talk about this. I'm going to talk about three things. What is the use of diet in CGM, use of diet with insulin pumps, and using medical nutritional therapy. What is CGM? CGM is a continuous glucose monitoring. We wear a sensor, which is it's a small filament that is there in the interstitial fluid. There is a chip which records all the data from the sensor, and then once we have a reader, it scans all the data onto the reader, which we can connect it to the computer and see what our trends are. Lot of advantages, and this is the new sensors that have come where the patient can actually see their own readings. It helps them to see what is the optimal diet, what they are eating that is making their sugar go up, what is the diet that is making their sugar be in the normal range. It gives a real-time dietary feedback on excursions of sensory glucose. They can know the hypo patterns during the day, where a timely dietary intervention is very invaluable. I'll come to a few personal experiences that I had with some patients. It helps clinicians in adjusting the in adjusting the diet rather than insulin, because when we are doing just a SMBG monitoring for 2 or 3 in a day, it doesn't give a timeline of the 24 hours. We have to really know what happens during the 24 hours. And it has helped me a lot to actually change the diet in the patient rather than just blindly up-titrating or down-titrating the insulin. And it also helps with the insulin dose titration for various fixed meals. So there are many paid dietary programs that are available which are using CGM, and they have got very good results. So I'm just going to be briefly talking about some of the patients I've seen. This was a patient recently I saw, and I think she was having a significant spike. This is at 6 p.m. So during the day it was okay. I increased her breakfast meal, but at 6 p.m. it is the main excursion that was happening. And she was having like a ridiculous amount of idli or dosa at that point, and I asked her to stop, and she actually became better after that. It was not completely resolved, but she became much better. So I wouldn't have known this 6 p.m. I thought if we would have checked pre-dinner or after dinner, I would have only known that this is actually a dinner dose that needs to be adjusted, but not the 6 p.m. dose. So sensor gives me that thing, and it's just a small dietary intervention that helped me control this. The second patient is again a patient who was having excess carbohydrate meal in night. This is 6 p.m. This is 8 p.m. About 9:30, 10. So I asked her to prepone the meal a little bit, and I asked her to reduce the carbohydrate intake with good results. If you see, there is no further spikes after this point. So the dinner dose is sorted. This patient was having frequent hypoglycemias at around 12 p.m. and was completely asymptomatic. We see this pattern of postprandial hyperglycemia again falling down with a hypoglycemia pre-meal. And this was the pattern initially when I put the sensor on. I saw the patient here. After that, I asked her to take a little bit of a heavier meal. Sometimes we ask them to take a little sugar and some coffee and biscuits. If you see, there is no further hypoglycemia after that. This patient was having, she wakes up at about 5 o'clock. This is 6 a.m. The breakfast time is actually here. So she was having low sugars, and I actually put a sensor to see what's happening before breakfast. And if you see the nighttime, the sugars are fine. It is just that at 5 a.m. it was going up. She didn't tell me this, and I asked me, please tell me what you're taking. And she takes a big cup of ragi malt at 5:30 a.m. So I asked her to stop it. It was fine. In fact, she was having low sugars, and I had to reduce the dose. So these are all the things that have helped me actually to actually control the diet part with CGM. And there's a lot of evidence to suggest that the quality of life in patients will improve with CGM. This was an interesting study. What they said, this is a real-time study. They used around 600,000 sensors, and they monitored what their A1C was according to it. So the more number of scans they do in a day, the more times they check their sensor, the more likely that they're going to do some intervention. They're going to make some adjustment to their meal pattern. And you see the more number of scans they are doing, the lesser is their HbA1c. This is a really good real-time study to suggest that CGM is the way to go. That is the future of diabetes. Now coming to next is the insulin pump. I'm just going to briefly talk about what is an insulin pump. We have a pump, we have a cannula which is placed in the infusion site. There is a sensor and a transmitter which transmits the data to this pump. The pump then regulates what amount of insulin that has to go into the infusion. We have pumps which are not fully automated to fully automated pumps which are available, where it takes care of everything. You don't have to do anything. It's like a completely artificial pancreas, and I've been using those. It's brilliant. The time in range is more than 90%. So what is available to us? Currently we have a basic pump and an advanced pump. The basic pump only gives insulin. It has nothing to do with sensors. It maybe just takes the readings, but it will not do anything. The next level of the pump is it will take up the readings of the sensor. It will stop the pump when the sugar goes low. That's actually a very good, because a lot of type 1 diabetic patients and children are actually afraid of hypos during the night. So it just stops the delivery of insulin once it recognizes that the sugar is going low. The next stage of generation is this newer pump 780G, which it has this smart guard technology where it continues to reduce the insulin, and it will also give boluses of insulin if the sugar is going up. Now coming to the diet part of what happens with the pump is, the pump will work only if you put in what is the carbohydrate estimation that you have. So carbohydrate counting is, I just want you to understand what is carbohydrate counting. That's all from this talk. Carbohydrate counting is very useful to selectively, significantly reduce the amount of bolus insulin that we give in children or in adults. If you can calculate the amount of carbohydrates you roughly estimate, it's going to really help with even the subcutaneous injection, especially in the pump. We have something called a bolus wizard in the insulin pump. It will determine how much we have. This is a setting at which, even if it is a fully automated pump, it has to require my settings to tell it how much insulin it has to give, or the ratio of insulin it has to give based on what the bolus. Basal it will calculate on its own. The bolus it will calculate based on this. So I put in something called an insulin carb ratio. For example, I tell to the pump, you give 1 unit for every 10 grams carbohydrate. So if the patient is putting a 50-gram carbohydrate, it will automatically calculate as 10 units, and it will give. We also put in something called an insulin sensitivity factor. That means if the sugar is rising at a certain speed, how much amount of insulin we have to give. So if I put 1 unit, you give 1 extra unit. If the sugar is rising 50 milligram per deciliter, it will give 2 units. So for example, the blood glucose is 200. It was designed to be at 100. So it is 100 more than target. Therefore, it will give a further 2 units to the bolus. It will calculate 12 and it will give it. So it makes our life very easy. Now quickly coming to the medical nutritional therapy. There are many forms of specialized medical nutrition therapy available, because diabetes needs equal balance of macro and micronutrients to manage malnutrition, dysglycemia, and other metabolic factors. These MNTs have low glycemic indexes and therefore are very useful as a supplement to the main meals. We have about, the requirement is about 40 to 60% of carbohydrates, 15 to 20% is protein, and a lot of it is also fat, because that also is required for our daily functioning, along with a lot of micronutrients. I'm just going to give you this slide just tells you what the ADA recommends, that how much we have to have, how much carbohydrate, how much fat, and how much protein we have to have. The DSNF, which is your diabetic specific nutritional therapies, or your MNTs, are close to what the ADA recommends. The ADA recommends this much amount of protein, this much amount of carbohydrate, this much amount of fat. It gives exactly that. And there are many other programs like the Atkins diet and everything, which give a high protein diet or a high fat diet, which is not valid on the long term. So MNT is a useful therapy to actually give as a supplement to our daily intake. So it is just shown that even if you replace it with a liquid formula, if you see that there is a very good reduction in your in terms of lifestyle. If it's only control, only with lifestyle, there is about a 7.3 reduction in the time in range with the CGM, whereas with your intervention and breakfast meal replacement, the reduction is much higher. So 13% reduction in time in range is a huge. So it really leads to a lot of improvements in glycemic variability. And, so suggest that.
Summarize.
So it's an effective treatment to alleviate glucose excursions. There you go, sir. Your wish is my command. So we have an endocrine quiz which we will be organizing. I have formulated a lot of questions. It's very easy. Please don't be afraid. There are multiple rounds of questions. There are 4 to 5 rounds, and the answers are very easy. As the rounds go on, the questions will become difficult. There is a cash prize. There is a lot of cups to be won. So please register yourself for the endocrine quiz in the lunchtime. Thank you, sir.